Welcome to the Senior Scoop, where experience meets community. Hi, I'm Deborah Samuel.
And I'm Kelsey Samuel. We're your hosts, bringing you real Santa Barbara stories, trusted advice and expert tips for seniors and their families. The Senior Scoop is proudly brought to you by SBSOS, your local support network for seniors. You can visit us at sbsos.care or call us on 805-946-0060.
Now, let's dive into this week's Senior Scoop.
I find this interesting. It's been a minute since most people have been in biology or health class, and now we're talking about topics later in life. And I love the way you broke it down with, the different stages, like if the ovaries are removed or if they're not removed. There's a lot of different things happening in our body that I think as women, we just don't understand.
Well, I think also that, when we start talking about menopause, people automatically think about women being out of control and having meltdowns, and I think there's a reason for this. I know with my own situation, it's like, well, things are not quite right. Like I'm not recalling things as easily as I once did, or have dry skin, and other issues. So, what are some common symptoms that women should be really sort of saying, hang on a second, if I'm having this, and this, maybe I need to go and see my gynecologist?
Right. Yeah, I think taking that step and talking to a gynecologist about it that frankly is interested in the subject, because some are not. Because a lot of gynecologists are obstetricians as well. And I always felt like these need to be two separate specialties.
Yes.
And in my practice, that's how I've arranged it. But
yes.
I did OB for a while, and then I did more gynecology. And as I've grown older, my practice has grown older with me. So I've had patients that I was the obstetrician for and delivered their babies, and now I'm looking after them in menopause. So that's a sequence of events, but it is important, I think, to say that the mindset of a gynecologist can be in one sphere or another. Yes. So talk to somebody who is interested in it, sees a lot of it. So, and I see a lot of it at this point. The symptoms that often occur first are, the sort of classical ones are hot flashes, night sweats, just having to throw the bedclothes off at night because it's just hot. And
yes.
Even though it's 30 degrees outside and your windows are open, that's a very common symptom. Other things will be that are more subtle, brain fog. Another one may be vaginal dryness, some pain with intercourse, urinary incontinence, and skin changes, hair changes, weight changes. And weight is something that we should really talk about, because low estrogen increases insulin resistance. So
let me say that again. Low estrogen increases insulin resistance.
Okay, so your body doesn't metabolize carbohydrates as well. And so there's that weight gain that occurs, and the patient classically will say to me, this has just happened the last 2 years, and I'm not doing anything differently. I'm eating the same, and I work out the same, and I've got now this belly.
Right.
And, so that's a big one. So all of those things. But it varies so much from person to person as to what hits them hardest.
So someone comes to you with these symptoms, and hormone replacement therapy seems to be the ticket for the day
I'd say.
And so let's talk a little bit about that, because I know that that has raised a lot of concerns with people in the past with having like excessive estrogen levels, etc. So maybe you can talk a little bit about its history, where you are now, and then obviously the difference between bioidentical, synthetic and compounding. Right. It's kind of this huge topic, but let's see how we go.
It is a big topic, and it's particularly interesting because in one area, doctors have not done the best to efficiently go through this whole thing. We did, in the late part of the last century, a use of hormone replacement therapy was becoming more popular. It was referred to basically as the fountain of youth because it did seem to slow the aging process down, but there were some complications with it, with both estrogen and progesterone, or particularly with the combination of the two. And there were some studies that were let's say, badly designed, wrongly interpreted, that caused one particular study, which was perhaps the most famous of them all, the Women's Health Initiative study, that was stopped because of some complications. Now, those things were basically misinterpreted, but it frightened the nation.
Yeah, it sure did. Yes, I remember.
And people stopped taking them, just dropped it right away. And others really didn't even consider it because they wanted to do things in a way they call naturally. Well, frankly, naturally means just aging, and if that's your choice, then it's your privilege to make that choice.
That's an interesting perception. Okay,
but we can slow it down.
Yes,
and we have shown huge benefits from the use of bioidentical estrogen therapy. And what I mean by bioidentical is that the medication that is used, the hormone that's used to replace the estrogen levels in the body, are exactly the same molecule as the body was producing. Now, earlier, 25 years ago, that wasn't the case. These were synthetic estrogens and progestogens. Even now, when we look at things in a way that we refer to as naturally, or let's say they want a plant-based. A person may say, I want a plant-based medication. Well, they're all plant-based, essentially, because we don't have estrogen-producing factories other than women themselves, okay? That's not a viable entity. And so what happens is they take estrogen, a phytoestrogen that's plant-based, and they change it to make it bioidentical. So it's now can be given in its purest form exactly what the body was missing. And we found that with estrogen itself, estrogen is a key ingredient to reverse most of those things that are happening at menopause. We use progesterone as well because that will protect the uterus of one side effect of estrogen that we want to avoid. Together, those two are actually a little more risky for the patient than estrogen might be alone without this other complication we're trying to avoid. So we've got to be cautious about that. And so where necessary, estrogen and progesterone are almost always given together and for systemic, full body use of the hormone. If somebody doesn't have a uterus, there's essentially no risk, really minimal risk of any complication from estrogen itself. So that's a good point to make there because it's easier to help a patient who is postmenopausal, who had a hysterectomy already for whatever reason, and we can improve their life and resolve these symptoms. The other thing that we've discovered is that a transdermal approach of the medication is a good one. If we can get that hormone into the body without it going through the intestines, then that's safer. There's lower incidence of breast cancer, lower incidence of blood clots and strokes. So that's another important point there.
Yeah, the heart health protective feature of estrogen is, I know, something that you're particularly mindful of speaking with your patients about.
Yeah. I can say without any doubt in my mind that for most patients, it is safer to be on hormone replacement therapy than not because of the benefits of estrogen and, where necessary, estrogen and progesterone, where we will improve things. We'll improve cardiovascular health. We'll improve the skin tone. We can improve bone health, really very important one there. And we can just,
Just vaginal health and-
pelvis.
yeah, and
the
pelvis.
pelvis health and all of the symptoms that can go along with low estrogen.